Today's seminar is about commissioning, and we've been, odd as you people in the NHS like to call, a journey through these seminars, and we've covered a lot of themes such as leadership and culture, the patient experience, and so on, all of which overlap. We come at the end to commissioning, and I think it's possibly appropriate for it to be the last one of these seminars, because it may be, particularly in the current scene, shifting as it is, that commissioning is one of the last most important levers left in the national system and indeed the local system to get right what it is that patients and the public actually want by way of their service.
At the moment, and the Mid-Staff's study showed this, I think, and others as well, that we're obsessed with protecting the NHS. And I want to protect the NHS as a concept, but I don't want to protect NHS providers who are palpably underserving their patients.
The first topic we came to was that it's different this time because of failure, because there's going to be an explicit failure regime, and because the Health and Social Care Bill, as it's currently constituted, actually allows for the first time properly for the possibility of organisations failing. One of my colleagues quite rightly raised the issue of thinking about banks and being too big to fail. And of course, in geographic localities where a provider organisation, there is no alternative, then I think we're likely to see some sort of, the government that in the shape of the NHS Commissioning Board or perhaps the Department of Health becoming the lender of last resort to those organisations.
In most CCGs, the GP leaders, which is very different from PCTs and previous organisations, are elected and not appointed. That means that you've got to do things right. Your colleagues have got to perceive that what you're doing is making a difference. Otherwise, you won't be in your post again next year or the year after. And I think that's very, very different from the current system.
Sure, and Andy's point, it makes it difficult for the powers that be to sack you as well.
It's difficult to sack you. It makes it very difficult for you to make difficult decisions when times are hard. But it does make you more accountable.
We recognise this is a difficult one. They'll be clear about saying what will happen if there isn't improvement, through to the extent of saying if there isn't improvement, we are going to start looking at ways of moving some of the work that you do to other providers. I think it was Paul Zollinger-Reid who said earlier, there'll be people queuing up to do some of this stuff. Yeah. So one of the messages will need to be, if you don't improve, what are we going to do differently? It doesn't mean closing down whole hospitals or whole departments necessarily, but we are going to be prepared to move work elsewhere.
When they do go wrong, what we heard today was clinicians in the new commissioning groups, one of the key things they need to do is to be very dogged about making sure that they follow through with their providers, but also perhaps asking for the right networks and support from other clinicians in the right specialties to be able to bring support and scrutiny to what's being done locally. Other things that might make a difference, contract currencies, whether it's pathways, years of care, individualised packages of care, or quality incentives that we heard about this afternoon.
And one of the negative things about the opportunities of the reform is people are accusing it of things it isn't. So my first message to everybody is, unless you change your mindset and relate more to what your patients and public are telling you and what they're trying to define as outcomes, then you're not going to be a successful commissioner.
But there was a positive sense on the table that because CCGs will be self-selected, that maybe there'll be a group that will be more inclined to engage with patients.
Do you think it will be easier? It sounds from what you're saying, it'll be easier for them to capture patient experience, and it may not just be through the interactions between the doctor and his or her patient. But that'll be easier for them than engaging the wider population in complex decisions about should we buy this or something else, and how much.
We recognise that that's something that no one's ever really done very well, and so the challenge is in making sure we do and do it properly, and that public and patients are involved in the commissioning decisions rather than just asked about something when we've decided it.
Yes.
When we did the Darzi community
care strategy, we were quite keen, as Patricia Hewitt was, on deliberative
Exactly,
process,
exactly.
rather than the Blue Peter, I'm going to consult you now.
Yeah.
It's a continuing relationship we need and different ways of approaching, otherwise it becomes nonsense.
Part of our sort of listening work has been engaging hundreds, thousands of the public in different groups. And there are different methodologies, but the hard-to-reach groups are the ones that always get forgotten, and they're the ones with the most complex needs. And some of our best meetings have been with homeless people, with the third sector involvement, housing, and local government. And I think one of the issues here is to not forget, as we won't, that CCGs aren't just about healthcare. It's about health and social care, education, housing, economy. And we've really got to make more of an effort to get out, because the services I've seen for the homeless are best designed by the homeless with the third sector engagement, and are worst designed by clinicians who don't have that day-to-day action and activity.
Clinical commissioning groups will need to take into account patient experiences, patient preferences, but GPs typically see the people that come through their door.
Yep.
How do they build in the views and expertise of the people, of the wider public, the people that they don't tend to see?
Well, there's two things. One is, over a 3-year period, most GPs see about 90% of their patients. That's number one. Number two, when I was a GP, I'm retired now, what was interesting was I got fantastic feedback about my hospital. I knew the consultant staff, I often knew the managers, but a lot of my patients were patients of the hospital, but many of my patients were staff in the hospital.
Right.
And I got a rich mixture back about some of the issues.
Yes.
So this time it's not about GPs trying to get hospitals to do things differently. It's about how GPs and hospital consultants are going to actually work together to develop new forms of care, particularly for older people or people living with chronic conditions. So I think what we might see increasingly is GPs together with hospital specialists, perhaps taking on a budget together, committing to run and improve those services in a different way.
One of the areas that we've tackled locally is maternity services, and we became aware of the issues around maternity through different channels, and that's what often happens in quality, whether it's patient feedback, whether it's clinician feedback, whether it's significant events, and often they all point to the same direction. What we've done is, one, made it an absolute priority, so we've got a specific commissioner for maternity. Secondly, we've got the Quality and Safety Committee that very much prioritises it, and we've got a specific work plan on this. And what we've done is looked at what the specific issues are, and said that, look, in order for us to be assured that quality is improved, we would like to monitor these particular areas, and we would like to monitor the action plan.
The medical profession is not always focused on outcomes for patients, partly because they only see one part of a patient's journey through the care system. What will the new system need to do to make sure we get those whole patient outcomes and experiences?
I think the proposed outcomes framework, the 5 domains, will help enormously. One of the arguments that clinicians always use is, how can you measure outcomes because they're too far long down the line? And in the GP contract, what they've done, where there is an evidence, is use process measures which you know will lead to outcomes. But the big issue is, and you can measure this in short term, is the patient-reported outcomes.
Yes.
So even a part of a care pathway could be measured by how satisfied the patient was. And what I really would like in community development is to start looking at patient-determined outcomes. But the patient-reported outcomes can be done now, both for the care pathway complex or whatever, and for individual bits of care.
In your area, in outer North East London, the PCTs in that area were some of the first in the country to structure practice-based commissioning around localities. What did you learn through that process that will serve you well for clinical commissioning groups?
I think localities are very important, because one of the areas we'll be able to focus on is localities collaborating to make a strategic difference. Often acute trusts provide services for a large area, and it's important that PCTs, clinical commissioning groups, work together. And what we've done, and our focus on quality, have been all clinical commissioning groups and all PCTs in the area focusing on the unified goals of improving quality. And that's made a big difference, and we're all united, and that leadership, or joint leadership, is very, very important.
Yeah. We need jobs working as CCGs to be attractive jobs, and to attract the right people. We need people who have got skills that are able to transcend the system. The table thought it was a really good thing that one of the premiums you get for GP-led commissioning is the fact that most GPs will have done some of their training in hospital and they understand the hospital system, giving rise to a better quality of conversation that will take place between commissioners and providers.
And we've had big organisations like SHAs, and nothing has come from them. Yeah. And in one sense, we almost need a disruptive technology to reshape the future, and maybe that's where CCGs are. Yeah. And because the big people haven't delivered on a big-scale approach. They haven't combined PCTs, apart from odd place like Manchester. You know what I mean? We've failed in the past.
So what I think is really important this time is that we're careful not to overload clinical commissioning groups with too many responsibilities, too many tasks, where they just become bogged down and overwhelmed potentially by it all. And I think where there's real potential is for them to be, in a sense, the stewards or guardians of the NHS outcomes framework for their local population.
Apart from their work as being part of a bigger public health ecosystem, working with health and wellbeing boards and local authorities, is the need to have a different relationship with their providers. The providers have the clinical knowledge, they've got a longer history of survival from at least 500 AD, and they've got, as I say, that's who the patients know and recognise, their providers. And how do you, instead of trying to micromanage input into quality, is how do you get the providers to define quality in a relationship, commissioner and provider, and then hold them rigidly to account for those? And just to make certain, you might want to have a bit of triangulation or get other people's experiences as to whether this quality indicator is all right. But put the pressure back on the providers of defining their quality and holding to account. And if they fail, it's very seen as a provider issue because they've failed to come up with the outcomes.
Anthony Samara's suggestion in one of the seminars, and it's one for considering, is that every trust, and I suppose therefore every NHS organisation, should have a Julie Bailey. What he said was, if there isn't one, invent one. And there is a need to have someone who, with authority, often moral authority, is able and willing to ask the really uncomfortable questions and, more importantly, carry on asking them until they get an answer. Happily or unhappily, I fear that part of my job is to ask those uncomfortable questions and, if necessary, provide uncomfortable answers. But that's one of the many things I will have to do. But anyway, thank you very much for coming today. I think this has been a very helpful seminar for me, and unlike most seminars, of course, this is for the benefit of the chairman, me, rather than you, the participants, but equally I hope you go away with some benefit yourself. Thank you.